Good evening, sir.
Mm. Is this live stream today? Because yesterday also I told you, no, the video is
Yes,
not
sir.
uploaded.
Yes, sir. It's live stream now.
Yesterday's video, it will go waste. It is not there on app. It will not. It's not there on YouTube. Many of my videos, when I know take classes, they often go waste like this. That was the sole reason I wasn't taking the class. I hope today it's live.
Yes, sir. It's live.
Fine. I hope the audio and visuals are perfectly fine.
Yes, sir. Okay.
Shall I start?
Yes, sir.
Good evening, everyone. This side, Dr. Abhijeet. Good evening, everyone. This side, Dr. Abhijeet. And today, the topic that I'm going to discuss with you guys, it is the electrolytes, the various electrolytes that are present in our body. And today, we will be giving an insight to all those electrolytes. So we already know that the Oracle has initiated a 90 days foundation life class for the university exams, right? Where we are revising all the important topics in the form of Q&A, that is the question and answer format, in a very crisp, concise, and conceptual manner, where I will be teaching you to write the answer, how to write the answer in the exam, right? So I will be dividing, I will be revising the entire topic, okay, in the form of Q&A. And obviously, the ones who are going to appear for the prof exams, obviously, it is beneficial for them, for the first year students, but the ones who are going to give INICET exam, okay, NICT is already done, right? The upcoming NICT or the NEET PG or the FMG exam, the upcoming FMG exam on January, they can also benefit from this particular session because all the electrolytes that I will be discussing up today, they will form a core foundational basis for the medicine also, right? So yes. So today's session also I will be like discussing in three parts. We have the long essay question that comprises of 10 marks. Then we have the short essay questions which comprises of 8 marks or 5 marks. And then we have the short answers that comprises of like 2 or 3 marks. So majorly I will be discussing the sodium and the potassium regulation, okay, the clinical significance, right? What happens when the potassium and sodium becomes low in the body, or if they are high in the blood plasma, what actually they will do. Apart from that, I will be focusing on the acid base balance, right? I will be discussing some disorders. Actually, I will be discussing like few points regarding with the disorders. Okay, more conceptually you will be learning in the surgery and medicine classes. Okay, apart from that, I will be like discussing the anion gap. Okay, that is very essential. Now, guys, why to choose Oracle? You already know for flexible learning, the recorded classes are must. They are already on the app. If you're not attending the live classes, you can just go on for the recorded version of the app. We have the live classes from 6 p.m. to 10 p.m. daily. We have the live classes from 6 p.m. to 10 p.m. daily, right? We have recorded the practical sessions also. The ones, no, the students appearing for the practical exams, just go through these practical sessions which are already recorded on the app, and just it will boost up your confidence and your marks, and you will just excel in your practical sessions. Apart from that, just 1 month before, if you guys will ask me what all you have to like revise before the exam, you cannot go on for the textbook just 10 days back. So that is something where the role of this express exam module comes in, where I have like this content is curated in such a way that all the important topics, keeping in view the all the entire questions from different university exams, they are just covered under 20 hours. Apart from that, we have the hard copy book set, guys. Obviously, these notes are curated in the form of question and answer. All the topics are like done step by step approaches there, right? Fun zones are there. clinical questions are there, multiple choice questions are there, right? Everything is like covered in this text booklet. Now, the foundational classes, we have already told you for flexible learning, okay? You can just go on for this particular part, right? We have the live classes from 6 p.m. to 10 p.m. daily in the evening, where you can just go on, you can interact with the educator live on the YouTube and obviously on the app also, and you can get your doubts clear there and then for that particular topic. We also have the express exam module where we cover the entire syllabus under 20 hours, right? We have one-to-one doubt clearing session, right? You can always book a prior appointment if you have any doubt related to any topic in that particular subject, right? Then you can just get your doubts cleared with the faculty. We have the hard copy book set. I've already told you we have for the basic three subjects, anatomy, physio, biochem, and also the practical notebook is there where Viva questions are even though covered over there. Then we have the question bank. I've already told you it is from the basic to the advanced level, where we are covering the entire questions of the previous year questions of INI-CET, NEET PG, FMG exam for previous 10-15 years. And we have curated clinical weakness. Nowadays, the trend has more no approach to those clinical beginners. So the expert team has created those questions for you people as well. So that once you're done with all the previous year topics, previous year questions, fact-based questions, you can also like excel into those clinical based scenarios. Now we have the practical sessions. We have already, I've told you, we have like demonstrated all the practicals in these videos which are recorded and which are available on the app. You can just go on for these videos just before the exam, and obviously that would help. Coming on to the subscription plan, guys, we have the foundational plan, okay? We have the advanced learning plan, we have the complete learning plan, and we have the ultimate MBBS plan. For additional discounts, guys, you can use my code Dr. Abhijeet 20, right? Now, guys, let us start with the very first question that is of 10 marks. Describe the regulation of sodium and potassium levels in the body and their clinical significance. Now, guys, you already know the sodium and potassium are very essential electrolytes, okay? They help to maintain the physiological functions of the body, right? For example, the fluid balance in the body, for example, nerve conduction, for example, muscle contraction, okay, muscle function. So basically, they try to control the homeostasis, okay? They try to control the homeostasis, and obviously, if there is any insignificant change, it will lead to certain disbalances, right? Now, for example, if you ask me, okay, the sodium guys, right? Now, you already know the primary function of sodium. The primary function of sodium. Okay, that is the, yes, from physiology, guys, you already know it helps in fluid balance. It helps in fluid balance. And you already know the sodium, it is a major component of the extracellular fluid. It is the major component or major component means the major cation actually in the extracellular fluid. Okay, so it helps to maintain the osmotic balance. Remember, guys, it helps to maintain osmotic balance between okay, between the, okay, let us look right like this. It is maintaining osmotic balance inside and outside the cell. Inside and outside the cell. Right? Inside and outside the cell. Now, that is something you have to remember, okay? So apart from that, this sodium also helps to regulate the blood pressure. Very important. It helps to regulate the blood pressure. Okay, it helps to regulate the blood pressure, okay, and the blood volume, right? Now, Second important function, one you already know, that is the fluid balance. The other one, guys, that you can just focus on, it is the nerve function. The nerve function. Obviously, you might have like learned in physiology, guys, that it helps to initiate the action potential, right? So it is important for action potential in the nerve cells, okay, in the nerve cells, right, in the nerve cells, right, and muscle cells. It also helps to maintain the acid base balance. Acid base balance. It also helps to maintain the acid base balance. It also helps to maintain the acid base balance. Okay. So it is regulating the pH of the fluid of the body, right? It is regulating the pH of the fluid of the body. Okay. And they have asked you how they are regulated. What is the regulation? I mean, we have to discuss the regulation of sodium. So remember, guys, if we just try to focus on mechanisms of sodium regulation. Sodium regulation. So remember the very first one, it is the kidney. Kidney. Now, the sodium, it is basically filtered by the kidney, okay, and its reabsorption, you already know, it is filtered and reabsorption occurs in the proximal convoluted tubule. You already know we have the Bowman's capsule, right, and we have the PCT. PCT. So sodium is basically filtered in the Bowman's capsule, then it goes to PCT where it is again reabsorbed back to the body. Okay, so yes, it is also even after we have the loop of Henle, then we have the collecting ducts, right? Collecting ducts. So there is a system, guys, that you might have learned in physiology. That is the RAS system, renin, angiotensin, aldosterone system. It is the renin, angiotensin, aldosterone function. Aldosterone system, that is the RAS system, guys, RAS system. So basically in response to, if guys, now just let us discuss the clinical significance. If there is low blood pressure, okay, let us assume if there is decrease in the blood pressure. Now we already know the normal blood pressure as of now, it is 120 by 80 mm of He, where 120 describes the systolic blood pressure and 80 basically describes the diastolic one, right? So if there is any decrease in the blood pressure, or I can say decrease sodium levels, right? So what will happen? The kidneys will release renin. The kidneys will release renin. Okay, the kidneys will release renin. Okay. Now, what this renin wish do? It will catalyze. Okay, let me just write like this. It will catalyze the conversion of angiotensin 1, angiotensin 2, angiotensin 1 to angiotensin 2. Okay, now this angiotensin 2 will actually stimulate. Now, what does this? It will do? It will stimulate adrenal glands, adrenal glands to release aldosterone, aldosterone, right? Now, now, what this aldosterone will do, you already know from physiology, it will help in sodium reabsorption. It will help in sodium reabsorption in kidneys. It will help in sodium reabsorption in kidneys. Apart from that, there is one more way, guys. There is one more way. Let me just try to okay. Let me just try to put it over here. We have something called as atrial natriuretic peptide, ANP, that stands for atrial natriuretic peptide. Now this is okay. Now let us suppose if there is any high sodium, if there is any high sodium, or I can simply say if there is high blood pressure, if there is high blood pressure. So what the heart will do? This heart will release ANP. It will release ANP, okay, which promotes sodium excretion by the kidneys. which promotes sodium excretion by kidneys, which promotes the sodium excretion by kidneys, right? We also have the baroreceptor reflex. So all this regulation, guys, it's a part of physiology. So you might have discussed this in physiology also. So the regulation of sodium, okay. So let us first complete sodium, then we'll come to the potassium part also. And please just try to understand the clinical significance also. Now, when I say clinical significance, I'm actually talking about the levels of the sodium in the body. Either it can be, yeah, okay. So just try to see over here, guys. You already know the sodium, it is the chief cation. Okay, it regulates acid-base balance, osmotic pressure. Requirement of sodium, it is 5 to 10 gram per day. Okay. Secondly, you have to remember what will happen in hypertensive patient. Requirement of sodium is 1 gram per day. Obviously, whenever a patient of hypertension comes to your clinic for no medicines, you always state that along with the medicines, you always say the patient that please reduce the salt intake. Okay, that is something which we always say in hypertensive patients. But the ones who are having hypotension, we always advise the patient to take more and more salt. We also advise salt capsules to that patient. Right. So remember, guys, the sodium, it is absorbed from the gastrointestinal tract and it is excreted from the kidney. So again, the very, very important part, it is the normal plasma concentration. It is 135 to 145 milliequivalents per liter. Very, very, very important. This question can be asked in the MCQ as well. This question can be asked in the MCQ as well. Now, if there is adrenocortical insufficiency, okay, what was adrenaline doing over here? You already know this adrenaline was actually absorbing the sodium, right? It was actually absorbing the sodium. This, okay, not adrenaline, it's the aldosterone which was absorbing the sodium. Let us just, okay. Now, adrenocortical, we have to cortex and medulla part of the no adrenal glands, and basically if there is cortical deficiency, what will not be released, that is the aldosterone. And obviously if aldosterone is not there, there will be no sodium reabsorption back into the body. Okay, so in that case there will be a decrease in the plasma sodium, there will be more sodium going out of the body via urine. And yes, so that will be resulting in hyponatremia. Hyponatremia, guys. So you already know aldosterone regulates the reabsorption of sodium from the renal tubules, right? So anything which is less than 135, or approximately we actually take it as 132 or 130. But as of now, just based on the clinical values, guys, if the plasma sodium level it is less than 135, then it will result in hyponatremia. Hypo means less, natremia means sodium. So yes, in coma state, anorexia, lethargy, if the tendon reflexes are decreased, right, the limb muscles, orthostatic hypotension, okay, the seizures, stomach cramping, in that case, we have this hyponatremia. So remember, guys, these are all those like what can result from hyponatremia actually. So obviously, seizures are very, very common, right? Yeah. So what are the causes, guys? The very first one, it is the diarrhea. Obviously, the fluid loss is more. Okay, the fluid loss is more in the body, even from the vomiting also. Chronic renal disease, Addison's disease, where there is adrenocortical insufficiency, where there is less production of the adrenal aldosterone, sorry, right? Renal tubular acidosis, okay, where you already know if the tubules of the kidney, the PCT is the loop of Henle, the collecting duct are not able to reabsorb the sodium back into the body. That will again lead to the tubular reabsorption. I mean, if it's not functioning, obviously the sodium will not be reabsorbed. It is already filtered from the glomerulus into the Bowman's capsule, and then it will straight away go out of the body, right? Even in hyperglycemia, high sugar, and ketoacidosis, these are the basic causes of hyponatremia. So this is one of the clinical significance that you have to remember. So what will be the clinical features? The person will be dehydrated. Okay. It will be having a low blood pressure. The normal is 120 by 80. If it becomes less than 90 by 60, obviously, it's an indication where the blood pressure is going low. The person can anytime go in coma or shock, right? Confusion, tremors, right? So that is something you have to remember. So yes, if sodium is more like than 125, it has particularly no symptoms, but it is less than this, we have nausea or something. If it is more towards 110, we have like more of these symptoms, right? And if it is less than 110, the patient may be in coma or any respiratory arrest. Now, what is the treatment? We have to restrict the water. For example, now why this treatment is there, guys? You already know if you take a glass of water and you put one tablespoon of salt in it, right? It's normal. But if you take two glasses of water in a single water bottle and you are adding only one tablespoon of salt, what will happen? Again, you have increased the water content, but the level of the sodium is already less. So automatically this says that you have to restrict the patient for like water and we have to give salt capsules to the patient. We have drugs like furosemides and anti-ADH drugs, okay? So that can be given and it is just measured after like 4 to 6 hours of these. We already measured the sodium concentrations after 4 6 hours. That is one of the like hyponatremia. Okay. Hypernatremia, guys, you already know basically when we are actually talking about, okay, let me just write it over here only. If we talk about hypernatremia, guys, it is basically high sodium. High sodium, okay? It is often caused by, okay, dehydration, or if there is hyper excessive sodium intake, that is the salt intake, right? So basically, hyponatremia, the symptoms, if you ask me what are the symptoms of hyponatremia, obviously, if it is more than 135 or 145, okay, 155, 158, that is hyponatremia. The symptoms will include thirst, agitation, we will have restlessness, right? Confusion, and very in severe cases, you might have seizures and also coma. Also coma, right? So that is the hyponatremia also. Now, coming on to the, okay, that is already given also. Yes, let us just try to discuss the potassium regulation now. Potassium regulation. Okay. Now, what is the role of no potassium? If I just try to decrease, I mean, let me erase this, guys, and let me tell you what is the basic function of the potassium. Although you know it from physiology, but let us just try to revise it. Now, the primary function of potassium, it is basically to, okay, it takes participate in the resting membrane potential. Resting membrane potential. You already know it is the major cation in the intracellular fluid. It is the major cation in the intracellular fluid. In the intracellular fluid. Right. So it is essential for maintaining the resting membrane potential of the cells. So it also helps in, okay, nerve transmission, nerve impulse transmission, nerve impulse transmission, and also the muscle contraction. Also the muscle contraction. Right. Now, apart from that, all we have more roles of potassium that it is helping in protein synthesis, cellular metabolism also, right? And also one important function that is the acid-base balance, right? So it exchange the hydrogen ions in process like if you might have heard about bicarbonate buffering system, so it also helps in exchanging the H plus ions in that case. So it also helps to maintain the acid-base balance, right? So yes. Now, mechanism of potassium regulation. If you ask me what is the mechanism of potassium regulation, although it's a part of physiology. But remember, guys, we have the very first one, that is the kidneys only. Now, potassium is basically filtered by the kidneys, okay? And it is basically okay. If the potassium is filtered by the glomerulus, it will go into Bowman's capsule, then into PCT, and then it will come into DCT, right? The distal convoluted tubule after loop of Henle and all. Now, in the DCT, basically what happens, the distal convoluted tubule, it is basically therefore reabsorption of potassium is reabsorbed by a DCT. Okay, it is reabsorbed by a DCT. Okay, so yes. Even guys, if there is a condition where there is high okay, let us just take one more example. If there is high level of aldosterone in the body, if there is increased levels of aldosterone in the body. So obviously, they will not try to absorb more and more sodium. But let us take a statement more contrary over here. If there is high levels of potassium in the body, okay, it will stimulate the aldosterone. It will stimulate the aldosterone, leading to increased potassium secretion, increased potassium excretion, right? Apart from that, guys, remember insulin also plays a very, very important role. Okay, insulin and beta adrenergic, they are the agonist, right? The beta adrenergic agonist. So basically, what does insulin do? Insulin also promotes the uptake of potassium into the cell. It also, the insulin promotes the uptake of potassium into the cell, right? Which lowers the potassium levels in the blood, which lowers the potassium level in the blood, right? Now, we have various causes of no. If the normal potassium level, it is basically from 3.6, okay, to 5.4, okay, nearly up to this, nearly up till this. Now, if the concentration of serum potassium is less than 3, guys, so there are various causes which can result in this. We have the Cushing syndrome, hyperaldosteronism, right? Obviously, increase in aldosterone, obviously it will absorb more sodium and potassium out of the body. Renal tubular acidosis, obviously I told you the DCT, which is helping in the reabsorption of the potassium, which was filtered by the glomerulus. If the tubules are not working properly, the potassium again will be excreted out of the body, and ultimately it will result in the decrease in the potassium levels in the plasma, right? We have adrenogenital syndrome, the prolonged cortisone therapy, intravenous administration of potassium free fluids. Okay, so if we are giving potassium randomly to the patient, obviously, okay, treatment of diabetic coma, yes, prolonged diarrhea. And apart from that, what are the clinical features that are associated with it? We have muscular weakness, tachycardia, cardiomegaly, and the cardiac arrest. Obviously, the muscles of the cardiac, they will actually relax, and thus it will lead to cardiac arrest. So ECG, very important. The ECG will show flattened waves with inverted T waves. Very important feature of the ECG. We have inverted T waves over there. What is the treatment? We have to provide, if potassium is low, just provide potassium. Okay. So they're given through the central lines. They're not given to peripheral veins. They're given to the central lines in the neck. Okay. I mean, yes. So obviously that is something you have to remember. So it is basically 3.5 to 5, 5.4. It's absolutely normal, right? Hyperkalemia, basically, if it is more than 5.4, 5.6, basically what will be, there will be weak pulse, slow heartbeat, cardiac arrest, abdominal cramps, heart palpitations, irregularities in the heart beat, right? So there will be numbness of the skin, right? Muscle weakness will be there, muscle paralysis will be there, right? It helps in the muscle regulation contraction. So obviously, if it is like more, so yes, again, it will lead to paralysis of the muscle. So yes, they have given 5.5. Yeah, it can be like 5.6 also. Okay, just to go by the latest one. Renal failure, Addison's disease, okay, diabetic coma, severe dehydration, right? Tumor lysis after chemotherapy. Okay, we have intravenous administration of fluid with potassium salts, thus causing hyperkalemia. Very important. Spironolactone angiotensin converting enzyme inhibitors and beta blockers. They are very, very important. They can be asked in the MCQ as well. Which drugs are causing hyperkalemia? Or they can give all of the drugs are causing hyperkalemia except. Obviously, it's a pharma question. It won't be asked over here, but just remember for that particular point also. Right? What are the clinical features that are associated over here? We have mental confusion, numbness, bradycardia, cardiac arrest. Over here in hyperkalemia, we will have elevated T waves. There will be widening of the QRS complex and the lengthening of the PR interval. That is again very, very important. Put dollar signs over here, right? Treatment, potassium, if it is above, we have to give intravenous glucose and insulin. Obviously, insulin, what it will do, it will take the potassium into the cell just by lowering the, yeah, the potassium levels in the plasma, right? So continuous ECG monitoring can be done and we can give bicarb to the patient, okay? Right. So that was regarding the very first question of today, regulation of sodium and potassium and their clinical significance. We have to mention all the points, the regulation, and obviously hypo and hyperkalemia, hypo and hypernatremia, they are very, very, very important. Right. Now coming on to the next question. Explain the role of electrolytes in the acid-base balance. Now, there are various electrolytes, okay, that help in the regulation of acidic base balance. Firstly, we have the bicarbonate, that is HCO3 minus, right? We have sodium, we have potassium, right? We have chloride, we have hydrogen ions, right? So they are playing a very, very important role in buffering acids, okay, bases. So they help to maintain this. Now, if we talk about bicarbonate, guys, we already know we have a bicarbonate buffer, okay? It is the most important, remember, most important buffer and most widely used buffer in the extracellular fluid, okay? So, yes. Now, you already know how does this work, guys? You already know we have carbon dioxide, right? We have carbon dioxide. Okay, it is produced by metabolism. See, all the cells of the body. Okay, we are giving oxygen to the cell with the help of arteries, and in return, the cell is giving CO2 to those veins. No, where the CO2 is coming from? This CO2 is basically the excretory product of all the metabolism pathways, right? All the metabolic no metabolism is occurring in the cell, and as a result we have like the CO2 right in the cells. So now this CO2, okay, which is produced by the metabolism that is taking place in the cells, basically it is combining with, okay, it is combining with water to form carbonic acid, that is H2CO3, okay, which will quickly dissociate into H plus and HCO3 minus ions. Okay, now obviously whenever there is excess of H plus ions, bicarbonate, that is HCO3, will act as a base and it will bind with this hydrogen, okay, to form carbonic acid again, right? To form the carbonic acid, which is then converted back to this carbon dioxide and water, okay, and it is exhaled through the lungs, right? And if there is excess of bicarbonate ions, what will happen? More CO2 is produced to increase the amount of hydrogen ions. Okay, thereby actually it helps in lowering the pH. Lowering the pH. Now over here, although I will be like discussing in the later aspects. If there, what is the clinical significance, guys, over here? Clinical significance. We have something called as metabolic acidosis. Metabolic acidosis. So what happens in metabolic acidosis? There is a drop in the bicarbonate ions, the bicarbonate levels. It can be due to kidney failure. It can be due to diabetic ketoacidosis. It can be due to lactic acidosis as well. There are various reasons of no metabolic acidosis. We have another question, but I'm trying to cover it over here only. Okay, it will lead to a decrease in the buffering capacity of the blood and just lowering the pH. We also can have metabolic alkalosis also. Metabolic alkalosis, it is increase in the bicarbonate ions. For example, due to excess vomiting or diuretic drugs like furosemides we are using, or very, very important, that is the excessive use of antacids like pantoprazole, rabiprazole. If we are using antacids excessively, it can also lead to metabolic alkalosis, right? It can also lead to metabolic alkalosis, right? Now, we also have, hmm, okay, hydrogen ions, they also help in maintaining, no, if we talk about the hydrogen ions, they are also no directly responsible for the acidity of the blood and tissues, right? Now you already know if there is more H plus, then the pH is lesser. If there is less H plus, the pH is more. Okay. So more acidic and like it depends on more basic also. Okay. Now what happens over here? There comes the roles of kidneys. Kidneys basically help to maintain the pH, okay, to maintain the acid-base balance, either by excreting H plus ions or retaining hydrogen ions, right? So basically, this is actually done in the distal tubule or the collecting ducts, okay? So where no hydrogen ions are actively secreted into the urine, actively by the help of ATP, okay, just to maintain the yes, the acid-base balance in the body, right? Even the role of lungs also come over here, right? The role of lungs also, they regulate the pH by regulating the CO2 amounts. Okay, it's the byproduct of H plus ions. It can again form one with water to form the carbonic acid. Okay, and that's the same story again. Okay. Potassium also, we have already discussed the potassiums and the sodium. So that is something you guys have to take away. Potassium and sodium have already been discussed. So bicarbonate and hydrogen, more you can write. Four of you, if you write in a 5 mark question, it's enough. Right? Even you can write about chloride also. Okay. Chloride bicarbonate shift, right? So that is the red blood cells. You already know they are exchanged across the chloride and the bicarbonate. They are exchanged across the cell membrane, right? So, yeah. Coming on to the next one. Okay, right on the physiological functions and disorders associated with calcium and phosphate imbalance. Calcium and phosphate imbalance. No, calcium, you already know that it helps in bone and teeth formation, right? Calcium also plays a major role in muscle contraction. This is the physiology part, guys. It also helps in muscle contraction. It also helps in nerve function. It also helps in nerve function. Okay. It is for nerve signal transmission, guys. Okay. So it facilitates actually the release of neurotransmitters. Okay. Neurotransmitters at synapses. You already know we have the synapse, right? We have the synapse. So basically over here, it facilitates the release of these neurotransmitters. It also helps in blood clotting. It also helps in blood clotting, right? Basically, it is involved in coagulation cascade pathway. It is involved in coagulation cascade pathway, right? And also helps in cellular signaling. Even if we talk about phosphate. So basically, phosphate also helps in bone and teeth formation. It also helps in bone and teeth formation, right? Basically, what happens, you already know the phosphate and calcium combines together to form hydroxyapatite, okay, which is like very, very no essential to form the crystals in the bone. Okay, they give provide strength to the bone structure and function. We also have, yes, it is used in energy metabolism, guys, right? So yes, it is a critical component of adenosine triphosphate, ATP. That is the phosphate, right? You already know it's the energy currency of the cell. We often call it as the energy currency of the cell. Energy currency of the cell. Okay. It also helps to maintain the acid base balance. Acid base balance. Right. So either by accepting or donating the hydrogens, okay, depending on the pH level. Now, physiological functions done and disorders associated with, okay, calcium and phosphate imbalance. Now, guys, remember the disorders associated with calcium and phosphate imbalance. Just try to remember one, that is hypocalcemia. Hypocalcemia, basically it refers to low calcium levels, right? What could be the reason of hypocalcemia? Yes, vitamin D deficiency. Either it can be hypoparathyroidism, right? Decreased pH secretion can also lead to this. If we have CKD, CKD means chronic kidney disease. Okay. Now, chronic kidney disease, the kidneys, impaired activation of vitamin D, obviously. Then, yes, even in the cases of acute pancreatitis, we have hypocalcemia, right? Magnesium deficiency also inhibits PTH secretion. There are multiple factors, guys. Okay, we have neurotransmitters. I mean, again, if the neurotransmitters are not working properly, we will have muscle cramps. Muscle cramps will be there. Tetany will be there, right? Obviously, shows sign where there is no um, twitching of these facial muscles. Cardiac arrhythmias can be there. There can be prolonged QT intervals, right? So obviously, if the calcium is low, we have to, what is the treatment, guys? We have to provide this with calcium. We have to provide this with calcium, right? Coming on to the next one, that is hypercalcemia. Hypercalcemia, that is the high calcium level. High calcium level. Now, what are the causes? It can be primary hyperparathyroidism. As of now, just remember, because all these disorders you will be dealing with in the pathology in the second year, hyperparathyroidism. Even guys, if there is lung cancer, malignancy of the lungs, or one which we have already discussed, multiple myeloma, okay, which release PTH related proteins, parathyroid hormone related proteins, or they can cause or osteolysis, right? So even the symptoms over here, we can have polyuria, increased frequency of urination, right? Increased urination, okay? Polydipsia, right? There is you will have like more thirsty you will be, right? Constipation, kidney stones. So obviously we have to give hydration in this case to dilute calcium in this, and obviously we can give furosemides. Furosemides also, that are the loop diuretics. This is the drug that can be used, right? Coming on to the phosphate, guys, you already know we are actually, if either it can be low, it can be hypophosphatemia, phosphatemia, and that is the low, okay, low phosphate levels. And one of the most important reasons you can remember, we have the chronic alcoholism patient who is a chronic alcoholic drinker. Okay, basically due to impaired absorption and utilization can result from this chronic alcoholism. Okay, hyperparathyroidism again is a very no hyperparathyroidism is a major cause of this hypophosphatemia, right? Muscle weakness can happen, bone pain will occur, right? Even rickets. Yes. Then we have hyperphosphatemia. Hyperphosphatemia, right? That is high phosphate levels that can basically, what are the causes? CKD, chronic kidney disease, hypoparathyroidism, right? In hypophosphatemia, it is hyperparathyroidism. In hyperphosphatemia, it is hypoparathyroidism. Right. So we have to give phosphate binders in hyperparathyroidism so that they can take the phosphate, and basically it reduces the phosphate absorption and phosphate can be eliminated through the kidney. Right. Now, coming on to the next one, next question. Significance of chloride and bicarbonate. Bicarbonate I have already discussed in the last question. Coming on to the chloride bit, I have already told you there is something called as chloride shift. Okay, so chloride basically plays a critical role in regulating the blood pH, right? There is something called as chloride bicarbonate exchange mechanism, or it is commonly called as chloride shift. Okay, now guys, in tissues, you already know we have CO2, which diffuses into the red blood cells. Now, what will happen, guys? This CO2 will combine with water to form the carbonic acid, that is H2CO3, that is the carbonic acid. Okay. Now, it will dissociate into H plus and HCO3 minus, right? It will dissociate into H plus, hydrogen ions and bicarbonate ions. Now, these bicarbonate ions are actually exchanged for chloride ions across the red blood cell membrane, right? In the lungs, the process is reversed, guys. What will happen? The bicarbonates enter into the red blood cell, okay, and in exchange for chlorides, right? So allowing carbon dioxide to expel out of the body, right? So that is something you have to remember. Normal plasma levels of sodium, I've already discussed 135 to 145, right? Normal plasma levels of sodium 135 to 145. Okay. We have already discussed potassium also, that is 3.5 to 5.5 milliequivalents per liter, right? So yes, it is milliequivalents per liter, 5.0, or just you can write like this, 135 to 145 milliequivalents per liter, right? And chloride also, it is approximately 98 to 106 milliequivalents per liter, right? So chloride also helps in maintaining the osmotic pressure, fluid balance, right? So that is you have to remember. Coming on to the another question over here, anion gap and what is its clinical significance? So what is this anion gap, guys? It is the difference between the measured cation. Now, when I say measured cation, I'm talking about the positive charge, and measured anion, that is the negative charge, right, in the blood. So it reflects the concentration of unmeasured anions in the plasma. Now you already know anion gap, anion gap, right? It is basically sodium plus, yes, Cl minus HCO3 minus, right? Cl plus HCO3 minus. That is the anion gap. That is clinically, basically it is 8 to 12 milliequivalents per liter. 8 to 12 milliequivalents per liter. Now, guys, it is the normal anion gap. Normal anion gap. Normal anion gap. That is 8 to 12 milliequivalent per liter, right? There are no significant amount. If what does this normal anion gap suggest, guys? That there is no significant amount of unmeasured ions in the plasma, right? Now, there could be two scenarios, guys. If we talk about the clinical significance, there could be two scenarios over here. There could be increased anion gap, that is more than 12 milliequivalents per liter. And yes, there could be no decreased anion gap, and that is less than 8 milliequivalents per liter. Now, increased anion gap can be due to diabetic ketoacidosis. We also have lactic acidosis. These are all the disorders that can release an increased anion gap, right? Diabetic ketoacidosis, basically, you already know there is increased production of the ketone bodies, okay, during uncontrolled diabetes. So basically, these acidic compounds accumulate, raising the anion gap. Lactic acid also, basically sepsis, shock, Obviously, the example like methanol and ethanol, they can cause renal failure and all that could again due to this. Even uremia, that is the renal failure. That basically it is in the case of chronic kidney disease, okay, where the kidneys fail to excrete the acids. Again, if the acid is more accumulated in the body, again it will release in the more anion gap, right? Even starvation or alcoholism that can also lead to it. Decreased anion gap, it is basically hypoalbuminemia, albuminemia. Basically, albumin, I have already discussed yesterday. Also, it's an important unmeasured anion where the albumin levels are low, such as in liver diseases or any nephrotic syndrome. So, yes, the anion gap may decrease, guys. Obviously, less albumin basically contribute to less negative charges. Even in the case of multiple myeloma, that is a cancer, right? In that case also we have the decreased anion gap, right? So that was regarding the anion gap and the clinical significance. Okay, list the causes and symptoms of hyponatremia and hyperkalemia. This is in the first question. We have already discussed the causes and symptoms. You can just refer to the starting video where I have discussed the causes and symptoms of both hyponatremia and hyperkalemia, where we have decreased sodium levels. We have decreased sodium levels and hyperkalemia, increased potassium levels in the blood, right? More than 5.5 and decrease basically less than 125. That is the hyponatremia. Normal sodium levels 135 to 145. Normal potassium levels, it is from 3.5 to 5. Right. So these are all the symptoms. We have already discussed the muscle cramps and hypokalemia. Okay, the question says hyperkalemia. So you just don't have to go for this. You have to write about hyperkalemia. In hyperkalemia also we have the muscle yes, muscle cramps are there, right? So thank you for watching, and these are the various social media handles where you can just get updated about the next class. Thank you so much.